Welcome to today's episode from the National Center for Health and Public Housing and the National Healthcare for the Homeless Council, where we explore critical health issues affecting communities across the nation. This episode brings together experts Frank Vitale, the National Director at the Pharmacy Partnership for Tobacco Cessation, and Dr. Maya Vijayagaravan, Director of the UCSF Smoking Cessation Leadership Center, moderated by Dr. Kevin Lombardi, Director of Research at the National Center for Health and Public Housing. Some of the issues that we will discuss include approaches to prevention and screening for unhoused populations and strategies for navigating difficult patient conversations, including the use of motivational interviewing.
This is Dr. Kevin Lombardi, epidemiologist, physician, internal medicine, director of research at the National Center for Health and Public Housing. I have on my left Mr. Frank Vitale, and on my right, Dr. Maya Vijayaraghavan, and we got a lot to talk about today. This is an issue that's always part of our lives, and it's one we need to revisit with new focus every era because things change for the patients. Things change with the medications, things change for the providers. So let's have a conversation and update ourselves. This is a conversation amongst experts, but we want you to bring yourself into it as well. Talk to your colleagues about this. Make yourself better, make everyone better. So we're going to start by sort of setting the stage here. And I want to start with you, Dr. Maya. Cessation counseling. Why do we do this in the first place?
Thanks, Kevin. Really happy to be here and would love to answer that question. So, you all may know that tobacco is still the leading preventable cause of death in the United States. The most recent Surgeon General's report that came out at the end of 2024 with a more recent estimate that over 490,000 people are dying from tobacco use annually in the United States. And if there's anything that we can do as providers, it is offering people the tools to help them stop smoking. It is one of the most important interventions that we can do. I will say it's particularly relevant to the populations that we're speaking about today because tobacco use is disproportionately concentrated among those experiencing homelessness, those living in public housing. There are many opportunities to offer cessation treatment as we're thinking about interventions in services where homeless adults and those living in public housing are seeking, and tobacco cessation can be very easily integrated into those service settings. And it is one of the most important things that we can do as providers to address tobacco use, to give people the tools to stop smoking and to have that be part of our regular conversations.
490,000 is such a mammoth number. It's so much.
Staggering.
It's one of those numbers that I think we should meditate on because, to be frank, we're dealing with this all day in different things. The patients that have hypertension, patients that have diabetes, tobacco is often in there just facilitating the advancements of these chronic diseases. And that 490,000, I mean, these are our patients, family members, these are big, big numbers. And I hear what you're saying about certain populations being just really uniquely at risk for this. And you also gave me something about perspective there. Because when we're talking about unhoused populations and residents of public housing, what I think we need is a different approach of how, as opposed to the purely clinical general population setting, we need to understand the sort of barriers they're facing and put that cessation counseling in the appropriate places. Am I in the right direction here?
Yeah, absolutely. You're absolutely right that the interventions that we propose, and there are, guideline recommended treatments for cessation that I'm sure we'll get into in just a bit, but it is really connecting the guideline recommended treatments with the context that we're, seeing our unhoused patients, residents, our public housing residents that needs to come together. And there are many, reasons for why that's not happening right now. And we can just talk about a few of them. From a provider perspective, there may be a lot of competing priorities. Other things take precedence, especially when you're seeing people experiencing homelessness, when you're seeing public housing residents that who might have many other issues that are pressing. And it gets deprioritized, even though it's one of the most important things that we can do to promote physical health, but also mental health. And it's important to make that connection, not only from the perspective of, improving hypertension or diabetes management, but actually addressing tobacco use will, also improve mental health outcomes. And there is robust literature supporting the fact that addressing tobacco use, particularly for people who have, anxiety and depression, is linked with improving those outcomes as well. So making the connection between tobacco and mental health is important. But there are other, barriers that get in the way, right? There might be perceptions that people are not interested in quitting. And what we found among adults experiencing homelessness and even public housing residents is that people are interested in quitting. They do make attempts. It is as much as the general population, even with high rates of co-occurring mental health and substance use disorders. They may be less successful at doing so, but this is where our tools really, and having them be aligned and tailored to people's lived experiences, this is where our role as providers really become important in taking the guideline recommended treatment and aligning it with the experiences of the populations.
Maya, you mentioned something that really stuck in my mind is that the willingness of residents of public housing, of homeless individuals who are unhoused, to their willingness to start the cessation process. And this is such an it's such an important part of the quitting process, is to be able to say, yes, I want to do it, to put that initial goal. My team performed an analysis of HRSA's patient survey, and we found that when we analyzed the questions for cessation and willingness to cessation, that we found the same thing, in that in many categories, residents of public housing specifically and HUD-assisted individuals had a higher desire and intention to quit than the general population. And when I hear what you're saying and I think about that, I say, what a huge opportunity as clinical providers to affect not only just this, but these behavioral health, mental health conditions, and chronic care conditions at the same time. It really is a winning argument. It really is. But you
And
also mentioned priority too, and that these are very complex patients with multiple social needs at times. And I guess I have a follow up for you, Maya, about this, and it's the exposures and addiction triggers that these populations have to manage. When you describe it to me, and when I think of the patients that I've seen, the trigger environment for them seems incredibly difficult. They're around these triggers with much greater frequency, and that's a much more difficult abstinence environment. What can we as clinical providers keep in mind when serving individuals that have identified themselves in this way about addiction triggers and about their exposures?
Mhm. Yeah, it's a really, really important point, and I think is so much part of the conversation of how to talk about tobacco use with those experiencing homelessness who may be living in public housing, because the triggers are long-standing, right? And for many, it has started from a very young age. When you even think about the initial trigger to start tobacco use, there are, long-standing, in all our studies, when we ask about age of initiation, it oftentimes is less than the age of 16, because people have seen, their family members smoke. They were always around tobacco use. They started really young and then over time became regular users and became users with other substances, and may also have mental health conditions that make it really hard. So when we're thinking about triggers, we think about not only individual triggers, but also environmental triggers. How, were they exposed, or are they currently staying in environments that allow them to stop smoking? So smoke-free environments. And these are less common in all forms of subsidized housing. They're common in one form of subsidized housing, the public housing authority housing, where there's a HUD mandate, but there is, not that consistent mandate in all types of housing. And even with smoke-free policies, they're hard to, continually enforce and maintain. You do require a lot of support from the residents as well as the staff and other people in the building. So it makes it hard to be consistent with having those environments that are conducive to smoking cessation. If you're, unhoused and you're staying in a shelter, that's even harder because you might have, indoor policies around smoking, but the facility itself might not be tobacco free. And as I've often experienced in our work, you have people coming outdoors and smoking, and that oftentimes becomes like the social thing to do in those settings. And that's hard to, overcome when you're actually trying to stop smoking. And then you might think about commercial triggers, and we have started thinking about, social determinants of health, but there are also commercial determinants of tobacco use. And this is really thinking about the perspective that you do have an industry that is marketing these products to a population where we know that there might be high rates of addiction, and that some neighborhoods are definitely more prone to having tobacco retailers. There is much more exposure to those products. There's also heavy marketing of menthol-based products to a certain population, African American populations that might be disproportionately represented among homeless adults and public housing residents. So there are those commercial drivers as well that we need to think about when we're thinking about addiction. So there's the individual, the environmental, the commercial, the social, and it's really having that perspective in mind when we're having those conversations with residents in public housing or who are unhoused, and acknowledging that those drivers are drivers that people need to, overcome in order to be in a space and an environment to stop smoking.
When I think of what you just overviewed for us, I think of that patient interaction. It drives to me the importance of one, knowing your community, and not just one group of your community, all of your community, including this, understanding those triggers. But I want to connect this to the patient interaction. And I want to ask you, Frank, about how those interactions go with individuals that are experiencing homelessness, or are they residents of public housing? Uh, is that a challenging environment to provide cessation? And what strategies do you use in that situation?
Before I answer that, I just want to comment on what you've been talking about, because there's another barrier here that I don't think we address very often, and that's on the part of the clinicians. In many respects, with these populations, what I've seen and what I've heard is that many clinicians feel sorry for these individuals from the perspective like they don't have a job, they don't have friends, they don't have a house, they don't have this. So let's let them smoke. It's the only joy they have. I don't want to take that away from them. They have nothing else. I'll feel you know negatively if I do that, and then they're left with nothing. So I think that is an unspoken barrier that we don't discuss, that I think many clinicians, if they examine their thinking, have. So I just want to throw that in as a
Honestly, Frank, I think we need to stop right there, because as you're talking, I've received this lecture is an important one, because even if we don't realize we're doing it, sometimes we do it. I think
Not agree more.
honestly, I've got to raise my hand and say I think I'm guilty of this, honestly.
Mhm.
And you've got my head spinning now. Maya, what do you think?
No, I cannot agree more, Frank. I think we are very much supporting, but we're also contributing, right? And it I have heard that perspective, and it's not just perspective among, healthcare providers, but it is also at the level of staff in shelters. It's at the level of staff in public housing. It's like at all levels, and it really requires a massive culture change. And
yes.
that culture change does require education, and it requires consistent messaging. It takes time. It's not something that we can do once and then, assume that it will stick. And it does require that we have champions. And that's why that model has been really helpful in supporting cessation and cessation workflows in healthcare settings where you do have champions, because you do, as providers, need those reminders. And we are lucky because we might have, like an electronic health record reminder if we have that. But if
Right.
you look at the social services side, there's no such, reminder. And you do need champions who can keep that front and central so that we don't forget that this is actually the leading cause of death and that we're not doing anyone a favor by not bringing it up. And look, there are people who actually do want to stop smoking, do want help. We're doing them a disservice by not bringing it up in our routine conversations.
I've had doctors tell me that they won't bring it up because they think that the patient will run screaming out of their office and they'll never see them again and they'll lose business, those kinds of statements. So that gets to your question, Kevin. It's not whether or not you should bring this up, it's how you should bring it up. And I think the physicians that are telling me that their patients are running out of their office are doing the exact wrong approach. So to answer your question, it's a matter of changing how you do this, not if you do it. And what I'm talking about is that as healthcare providers, most of us, because we are educated in our particular area, we know our stuff. And let's just use the example of somebody's having heart problems and they come to see a doctor. The doctor says, you have to do this, 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 and this. And we just go away and we accept it and we do it for the most part, most of us, if we're good patients. But with behavior change, it doesn't work that way. Because if we start to do that with patients and we end up telling them, you have to do this, you better do that, you better blah, 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 we end up becoming their mother, hollering at the naughty child for doing something wrong. And so what happens how does the patient respond? It's the same way we respond when our mothers did that, we resist. So I always use that example because I think people get it. So it's not about us telling them they have to quit. It's us asking them such powerful questions and providing them with such pertinent information that they tell us they want to stop rather than us telling them they have to stop. And that's where motivational interviewing comes into play. And unfortunately, we don't have time to go through all of it in this talk today, but with the on the National Center website, there's a bunch of trainings that I have that people who are listening to this can access. But in general, what you want to do is ask open-ended questions that begin with how and what, so that engenders a conversation. You don't want to ask questions. You don't want to say, don't you know you should stop smoking? Because everybody's going to say yes. There's not a conversation there. It's just a yes and no answer. So that's one very simple, quick thing that you can do after listening to this, is to phrase your questions in such a way as asking what and how, and then providing patients with very clear-cut reasons about how their smoking is affecting their life. I always like to say this in my lectures. If a patient is smoking, it's either causing the illness that you're treating, exacerbating symptoms of that illness, or we know that people who smoke get sick more often and take a lot longer to recover from anything. So it affects the immune system. So even if it's not apparent to you, even if they're not exhibiting some overt symptoms, their smoking is negatively affecting their health. And therefore, it's incumbent upon us to address it.
Yeah, and you demystified some stuff there. And I think often when I think what really triggers me to prioritize smoking in the conversation, it's often looking at the patient's skin, physical exam. I'll ask the question with more intent instead of, say, to be frank, treating it like a bubble that I need to check, which logistically speaking is what it is on the medical record. But it becomes more of a conversation. And the reason is I don't like having those paternalistic, maternalistic conversations with patients.
Nobody does.
For us either. And I like the way you phrase the questions. And I'm thinking of when I've been successful and when I haven't. A lot of what you're saying makes sense. And we really need to take away that paternalistic perspective and see the patients where they are. And it seems from what I'm saying, is from what I'm seeing, it's an easy sell because it's easier for the patients and it's more comfortable for us too.
Absolutely. So that then gets to how you're having these conversations. So just as an example, with someone who's unhoused, obviously they don't have enough money to pay for a home. That's part of the reason why they're unhoused. So how are they buying these cigarettes? How much is it costing? So if you're talking to somebody, hey Frank, let's add up how much you're spending on cigarettes a year, and it's maybe $3,000, because that's probably the average around the country right now. What could you do with an extra $3,000? So it's those kinds of questions. How would your life be different if you didn't smoke?
You are planting the seeds in the mind of the patient.
Right, right. Or one thing I like to say to people is, what would have to happen to you for you to consider quitting?
Now, what kind of responses do you get from patients that are obstinate about this?
Well, very good question. So, if somebody says to you, well, I'd have to get lung cancer, then you can talk about what actually happens when you have lung cancer and what the treatment is, et cetera, et cetera. Because I think there's this misconception, well, I know there's this misconception in this country, especially, that there's a pill for everything. So if I get lung cancer, all I have to do is go to the right doctor, and he or she will give me the pill and it'll take care of it. And so you break through that barrier and help them understand the reality of it and what actually does happen. But you're not going to do that unless you ask those. You're not going to get that information from the person unless you have that conversation. And you're not going to have that conversation unless you provide them with enough information about what's going on with them and ask those kind of open-ended questions.
I like a lot about that approach, and I'll tell you some things that really stick to my mind. One, the importance of positive health marketing. We are, as clinical providers, we're marketing services. In many ways, we're consultants to the patients. That's how they treat us, and that's how they respond to the information. And a lot of data tells us, and by a lot of it, I mean all of it, that positive marketing is more effective than negative marketing. And what you do is you don't lead with cancer, right? You save that for a specific type of person who's making a specific type of decision. And when you give it to them, you give it to them in an educational way. So you use the information very judiciously, and it seems that if you're doing this right, each patient is getting a different product. They're getting the cessation tailored to what their individual situation is. And when I think of that, I think, well, that's a lot like what we do in other things in medicine. Nobody's getting the same mix of their hypertension, diabetes, and kidney drugs at the same time. No one's getting that. Everyone has a tailored approach, and we should take the same tailored approach to cessation because, frankly, it's just as important, if not more.
All cessation is individual. It all has to be tailored to the individual. Now, that's intimidating for a lot of clinicians, especially I train a lot of pharmacists, and they get antsy about that because they're used to, this is the illness, this is the medication, this is how much you take. They're very structured and rigid. But I also think that that's the fun part of this because it is different with each patient. And to your point about what do you do with the obstinate patient, I think most of the time those individuals don't have a clear-cut reason to quit. There's no motivation there. So our role as clinicians is to help them find that motivation. And 90% of the time, that at least in my experience, it's not health. There's something else going on that will be more pertinent to their life. Because the example of lung cancer, that's so far in the future, it might happen, who knows, whatever. I might get hit by a bus before then. But if they don't have enough money, if their family is complaining about it, it could be anything. Unless it's hurting them, there's no bad reason to quit. To tell you a really quick story, I had a woman who was close to 80, came into my office one day frantic. I have to quit. I have to quit smoking right now. And I said, Mary, all right, I'll help you. No, you don't understand. I have to do it right now. And I said, well, I've been working with you for a couple of years and you really haven't been interested. So what happened? And before she answered me, I said, "Oh, you were just at your doctor's and you got some bad news about your health." And she said, "No, no, no, this has nothing to do with me. I'm going to live to be 95. It's poor little Fifi."
Mm-hmm.
And I said, and I didn't laugh, but inside I did, but not outwardly. Now, who's Fifi? Fifi was her dog. And she
Mm-hmm.
had found out that her dog had
Good that you
COPD.
asked, Frank. If Fifi wasn't the dog, you would have been in trouble.
Right, right. But the dog had COPD. And
Mm-hmm.
that's true. And little animals, dogs and cats and birds can get COPD, lung cancer from exposure to secondhand smoke. So that's why she wanted to quit. So, of course, what did I do? I said, "Mary, that's a fantastic reason. I'll do everything we can to make a healthy home for Fifi." And lo and behold, it took a couple months, but she quit. So I
You know,
always use that example in my trainings because people think it's silly and it's frivolous, but it's not. It was her very strong internal reason for wanting to do this. So I never said another word to her about her health. I never said anything to her about anything other than Fifi, and it worked.
you know what I love about this is one, it's a great story of clinical competency. Congratulations for that. But two, you hit a target. Outside of everything, you hit a target. You gave that patient exactly the message they needed to find. And I have a feeling if we think about every patient, that there's a message for each of them. We just need to find it. And when you
Right.
find it, it feels good. And when you start getting good at this, you feel like a better provider. So that's my addition to the sauce. Maya, do you have something to add to our sauce here? What do you think?
I have two things. One is, this is a good time to make a plug for the Prescription for Change website, which has a lot of resources, many that Frank were just talking about. It is free. But one of the things that, can be easily accessible is having a conversation with patients, especially around using motivational interviewing. So what are your triggers and how can you address them? And what are your reasons for stopping smoking? And the same question that Frank mentioned, what is getting in the way of you stopping smoking? So there are toolkits actually on the Prescription for Change website where you can have it all in one place, use it. It can guide your conversation. It can help, you use motivational interviewing during your conversation. So I highly recommend if anyone is interested to just go to that website because there's a ton of information. The other point is the point about pets. Now, we just finished this large randomized controlled trial of, a smoke-free home intervention in permanent supportive housing for adults who are formerly homeless. And, we ended up asking what their primary motivators for those who are interested in adopting a smoke-free home, what their primary motivators was for doing that. And pets is one of the top motivators. It is hands down one of the main motivator for not smoking in their homes. And these are primarily, single adult, multi-unit housing, permanent supportive housing for adults who are single adults living in permanent supportive housing, long-standing history of homelessness, mental health, substance use, other disabilities. Many of them have pets. They are so integral to their lives, and just knowing information about how smoking can harm their pets is really like one of their main motivators. So I completely agree with that story. It comes up all the time. And, maybe that is an avenue for conversation,
Right.
just as, Frank mentioned the cost of smoking. And then obviously health is there, but also mental health. And it's, our job to make these connections and hear our patient stories to be able to help them make those connections for themselves as well.
Mm, there is a lot to work with to personalize care here. There's a lot here. And what I'm thinking about as a provider, how I want to get better at that, right? This is something that's not just this process is a clinical process that's not unique to tobacco cessation. We're talking about patient motivation and change making here. And when I think about it, and I think about the information I've heard today and how that helps me, it helps me to visualize where I need to focus to get better. And that's here. One, the environment, understanding the myriad of factors, as Maya so eloquently went over. She described the different commercial factors, public health factors, epidemiological factors that the environment that our patients live in. And the other thing is, from Frank gave us pictures of that motivation. And that one, we need to understand that environment, but by understanding that, we can get more specific with how we're treating patients. And it really emphasizes for me the importance of just knowing that information. Just like when we have hypertension or we have diabetes, for example, knowing the kind of dietary choices that are being imposed on our patients, the type of exposures to these very dangerous foods. It's the same kind of thing. And I'm wondering if we can talk a little bit more about that. I'll call it the ecosystem effect here, Maya. When we think of you mentioned the unhoused individuals and the residents of public housing, those different effects that they're feeling, and you mentioned commercial. Now, I was wondering if you could tell us some more about how those affect the patient and how often the patient is exposed to those in these communities.
Yeah, I think that the exposure is pervasive. And that is what makes it so hard, because that same level of exposure doesn't exist for groups that are unhoused and that may have, gone through periods of homelessness and then where they ended up in public housing. Like that there is something really true about the statement that there is a disparity in exposure and access that have led to high rates of use among adults experiencing that does not exist in some of our other populations. And that does make it hard to stop smoking. And we as providers need to acknowledge that, but not let it stop us in providing the treatment that we would provide people who are, who are smoking and interested in stopping smoking. But the message really comes through from the framework of, hey, we know that you've gone through so many things. We know that tobacco is used as a coping for many of the things, the traumas that you've experienced, that it goes hand in hand with the alcohol that you're using, that you're also using cannabis, and then the two go together, that you feel like it's really helping you treat your depression because you're doing, it allows you to deal with the anxieties of being unhoused. Like, we acknowledge all of that and validate that that is the, decision that people have made. But then it is, the discussion around moving them and using motivational interviewing is to help people come to those conclusions for themselves. And it takes time. And as providers, I oftentimes have residents ask, like, well, I've brought it up, 5 times, and people are not interested. But this is your shifting behavior, and it is a continuum, and it is a conversation that we keep having. And it is bringing in that understanding that there are many triggers, that you do need to tailor your counseling to match those triggers. You're not going to have, an answer for everything that people are going through because it's really hard, but you're helping people, come up with solutions that make sense for the environment that they're in. And you know, you're also generating interest in some of the guideline recommended treatments and allowing them to know that they don't have to do it all on their own, that there are aids to help them, that taking the aids can actually increase their efficacy in stopping smoking. And, I can't tell you the number of times I've had these conversations where people feel really strongly that they internally lack the willpower to do this. And it is sort of, acknowledging that that's their belief, but also providing them the information that, okay, we know that, it's really important for you to feel like you need that willpower, but let me suggest some tools, some medications. Let me have these conversations to coach and counsel you on smoking cessation that might actually get you to the point where you feel you do have the willpower and you have the tools to help you stop smoking. So I think the conversation, you know, ideally should move towards taking the onus off and sort of like the blame and the failure that comes from not completely stopping smoking, to moving that to a discussion where you acknowledge all of the reasons for why people are smoking. You make known really clearly that they can do it and that there are tools available for them to do it. And you're there with them along the process.
The proliferation of smoking aids, pharmacological aids, over the past 10 years has been astounding. There really used to be only just a handful of options available for patients, but there really is so much more, and there's more every year. And I was wondering if either of our guests had some thoughts about having the conversation about pharmacological aids, about medication therapy, and how we should bridge that with the patient. Should this be a first visit thing? Should this be a second visit thing? And how do people like to have this information provided to them?
Well, when to do it, I think you have to gauge that by the particular patient. There's no problem with bringing it up early on to have them understand that there are options. As Maya said, I think many of these individuals, most of the public doesn't know that this stuff exists and it can help, etc. So yeah, I'm all for bringing it up right away. And from my perspective, it makes no sense to me not to use it. I think many people, especially men, don't want to use it because they think that quitting has to be something that they just hunker down and do it. If I'm a real man, I can just stop it. And to that point, I always say, well, if you broke your leg, you wouldn't tell the doctor, oh, I'll just let it heal on its own, or you don't have to do anything, or I don't need any pain medication. So it's the same thing. Those aids are there, they help, and they're meant for short-term use. So you're not going to get hooked on those like you are on cigarettes. And I and my colleagues use them all the time with almost everybody. There probably isn't a patient in the last 20, 30 years that we haven't used something with. And even if they're resistant, I usually ask them, just do it for the first 2 weeks, just to get you over the hump. And I think if you do that and get them started, then they'll see how much it's helping. And even nowadays, with the nicotine gum and the patch and the lozenge, you can start that stuff a month before you quit. Mm-hmm. We've learned that all those parameters that they put on them when they first came out aren't really necessary. What I have seen is, tell somebody, okay, you're smoking 20 cigarettes a day. I'm going to give you the lozenge. Just every other cigarette, put the lozenge in. And it's just a way to get them acclimated to it and to see that they're not going to fall apart. Their life isn't going to come crashing down if they're not smoking. And it starts to break that habit, that connection that they have. So yeah, I'm a big advocate of the medications.
Yeah, no, I agree with Frank too. Bringing it up early is really important because I think, and I rely on my pharmacy colleagues for this because they've said so much of the guidance, right? We know that smoking is a two-part problem. There's like the physiologic aspect of nicotine dependence where, if there are medications that can help with the withdrawal symptoms, there's no reason to go through those symptoms. And it actually might, increase your chances of quitting if you are open, willing to take those medications. And there's the behavioral aspect. You're working on your triggers, your cues, and coming up with your list of motivations and to stop smoking is the combination of the two. And even within medications, we prefer combination medication. So you're doing the patch and the gum or the lozenge. Or if you're doing, bupropion, you're doing that with NRT. You can also start with varenicline or Chantix. So it's having those discussions early on. And I 100% agree with Frank that, starting them even before someone is, saying that they want to set a quit date, but they're thinking about it and getting the medications on and, having the patients build their own self-efficacy around quitting is really, really helpful because it breaks down a lot of internal barriers that people might have, that it's like an all or nothing kind of process. And really what you're trying to help people see for themselves is that it is a continuum. So today you're able to delay your first cigarette by like 3 hours and you use the patch to get you there. That's great. Tomorrow you're going to try and delay it by like 8 hours. So it's having those kinds of conversations and using the medications can be really helpful to build self-efficacy.
I don't know about you, Elena, but I feel uniquely prepared to face these challenges. And I want to take a moment to one, audience members. Are you at a FQHC or PHPC? If so, thank you for your service to your patients and our country. This is Dr. Kevin Lombardi here with Mr. Frank Vitale and Dr. Maya Vijayaraghavan. Maya, Frank, could you each give us a one last hook of what you have to say to the providers before they go see their next patient? Frank, you first.
Okay, so quitting is a process that occurs over time. It's not a discrete one-time event. It's learning a new behavior, and that new behavior is not smoking. Remember that all your patients, everybody that you have who smokes, had to teach themselves how to do it. So this is just a process of teaching themselves how not to do it. And there's bumps along the way. I always liken it to riding a bicycle. I would think 99% of us did not get on the bicycle and just zoom down the street. We fell off, figured out what we did right, what we did wrong, and then got back on. So that's all this is. And you as a clinician, if somebody relapses, that doesn't mean they're a failure. You want to ask them, what did you learn about yourself during this particular attempt? And then use that information to build on the next attempt.
I will add that, for all of you who are providers, your patients really need you. And they really need you, especially when it comes to providing support for smoking cessation. And one particular reason that they especially need you now is just given the current climate, particularly for smoking cessation services, where we as providers can really step in and provide access to treatment, provide support for cessation. And now more than ever, this is really a time for all of us to get in there and have these conversations with our patients during every single encounter.
Well, I don't know about you guys, but I'm ready to ride these vibes right into the exam room and start to create some success in there. Elena, that's the show. It's all yours.
Oh, well, thank you so much. I just want to thank our amazing experts and Kevin, Dr. Lombardi, you facilitated this so well. I appreciate everyone's time. There was just one quick thing I just wanted to add was that recently I had the opportunity to present a publication from some clinical researchers in Boston where they found patient navigators were really vital to also getting people screened. And those who were randomized to the patient navigator arm, 43% had their lungs screened at the 6-month point. So, which is 9% compared to that did not get a patient navigator. So I want to thank you all and just thinking
Get
about
out there and use
things.
your CHWs, as that's what I'm hearing. Get those CHWs out there.
Absolutely. Absolutely. Well, that sums it up. Thank you so much all for your time.
Thank you.
You're welcome. Thank you.
On behalf of the National Center for Health and Public Housing, this audio training is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $668,000 with 0% financed with non-governmental sources. The contents are those of the authors and do not necessarily represent the official views of nor endorsed by HRSA, HHS, or the U.S. government. For more information, please visit hrsa.gov. On behalf of the National Healthcare for the Homeless Council, this audio training is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of awards totaling $1.78 million with 0% financed with non-governmental resources. The contents are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. For more information, again, please visit hrsa.gov.